Hello, and welcome to this extra special Halloween episode of Itsy Bitsy, where we're going to be discussing nightmares with Lauren Prince, who is a clinical psychology student with a focus on nightmares and sleep. Hi, Lauren.
Hi, Sienna. Thank you so much.
Yeah, of course. Thank you for being here. So before we get into all the stuff that you're working on now, I wanted to ask you where you grew up and what you were like as a kid.
Yeah, so I grew up in Rosenberg, Texas, which is outside of Houston area. As a kid, I guess I would describe myself as kind of a goofball, like not a class clown because I was very good in school and didn't want to get in trouble. But outside, recess, we're in lines, I'm making jokes, I'm trying to have fun. So that's how I would describe myself. Yeah.
Oh, that's so cute. Awesome. Thank you so much. Can you introduce yourself and the work that you do now as a grown-up?
Yeah, so my name's Lauren Prince. I am a fourth-year clinical psychology doctoral student at the University of Tulsa. So with being a graduate student, especially in clinical psychology, that means I have a lot of different roles. But my main role that I get paid for and that I'm here for today is I work as the lab coordinator for Dr. Cromer's Sparta lab at the University of Tulsa. And part of that role is I coordinate their current clinical trial, helping kids and teens with nightmares get better.
Yeah, I was wondering if you could introduce that specific trial in more detail and talk about how it works, how you find your patients, things like that.
Yeah, so this is actually Dr. Cromer's fourth trial doing it. This is my second trial that I've worked for her with. And so it's a collaboration with the University of Tulsa and the University of Oklahoma. So Dr. Cromer is at the University of Tulsa and Dr. Tara Buck is a child psychiatrist at the University of Oklahoma. And they both are the principal investigators for the trial. And so with that, we currently are helping kids ages 6 to 17 who have chronic nightmares. So to be eligible for that aspect, we require kids to have at least one nightmare per week for at least 1 month and not have any sleep apnea or circadian rhythm disturbances that might be interfering with the nightmares or kind of perpetuating them. So we primarily, I guess, for your question with how we get participants, we do both active and passive recruitment. So passive, we have flyers at different locations in Oklahoma. More active, we get the University of Oklahoma's child psychiatry clinic in Tulsa's patient list, and we're able to call all the patients on the list each month, like any new patients, basically. We're calling them each month asking, does anyone in your household have nightmares that we could potentially help? And then we do a screening process. And if they're deemed eligible, then they can choose to join the study at that point.
Okay. How did you start studying sleep in kids? It's a very niche subject. I'm curious about how you got there.
Yeah, it's kind of funny. I mostly applied to Dr. Cromer's lab because I was interested in trauma just generally and how trauma can affect people. And so I kind of just broadly liked that idea. And then Dr. Cromer accepted me and I was immediately put in this role as her graduate assistant and as coordinator. And so it kind of just happened, but I really love it. I love how you can help people, especially with some of these just behavioral principles. And my sleep has gotten so much better. I'm very rigid in some of my rules though. Sometimes people will be like, do you want a soda? And I'm like, what time is it? It's 3. Can't have caffeine. But I know for me, if I have caffeine after 3, I will not be able to sleep. If I have it too close to bedtime, I'll have a nightmare. So I know what works for me. And I know some people are different and that's okay too. So all this to say, it kind of just happened. But I really enjoy this work now.
Yeah, it sounds really fulfilling. I was curious about how you distinguish having nightmares from having nightmare disorder. Is it like you said, having one nightmare a week qualifies you as having nightmare disorder?
That's a great question. So what classifies nightmare disorder is that the act of having the nightmares is distressing and impairing to your life. So what we're really looking for there is that it's causing distress in terms of life, people with nightmare disorder are typically like they're maybe missing school or they're going to school, but they're so tired because of the nightmares that they're more cranky or they're getting upset or they're having more behavioral difficulties, or they might also have trouble going to sleep, or they're not even wanting to go to sleep. They're avoiding sleep because they don't want to have nightmares. And so those are all factors that make the nightmares also more likely to happen, and the cycle continues. So nightmare disorder in terms of like DSM-5 criteria just requires that people are having recurrent nightmares that when they wake up from them, make them alert, they're distressing and impairing, and they're not due to any other causes.
Is nightmare disorder very common?
That's a good question. I was just looking at the numbers actually earlier today. What's hard about like knowing prevalence for nightmares is that a lot of people just don't ask about nightmares. But there was a recent, or I guess it's been a couple years now, one of the former students in my lab did a systematic review on research to understand prevalence in kids, specifically populations. And so nightmare disorder, and based on her systematic review, suggested that about 3 to 6% of children are meeting criteria for nightmare disorder. So not a ton, but also more than what you see with other disorders that maybe are more talked about. Like schizophrenia is like less than 1%, but a lot of people, you hear schizophrenia, you're like, right, but you might not hear nightmare disorder and be like, oh, that's a thing. So yeah.
Yeah, and it sounds like it could be higher. There's no way to know if the question isn't being asked all the time. Yeah. Do you think that, or have you found that nightmares are more common in adolescence than in adulthood?
Yeah, usually that's what research will support, that it's more common, especially in like 3 to 6 is what some research will say, like before adolescence, and then it goes down. But I don't know how much we've really done like a longitudinal, I don't think there has been, that I'm aware of at least, like a longitudinal study to fully know like what are the prevalence and how it changes over time.
Is there an understanding of why that age range specifically is more prone?
Yeah, that's a good question. I feel like most of what I'm remembering or hearing is like mostly talking about the fact that there's just more imagination going on. And so they might be more likely at that point to be more imaginative and having things like that. But
are you noticing that most of them are having a recurring nightmare where it's the same dream that they're reliving over and over? Or are there patients where it's a different but still impactful dream?
That's such a good question. And, we used to ask that at our previous trial. We like specifically asked, but we don't ask that in this trial. And what we only actually asked them to tell us about their scariest nightmare. So they're not really required to tell us that much about nightmare content. But my understanding, kind of more anecdotally, is that you're more likely to see those like reoccurring nightmares if it's trauma related versus kind of more the idiopathic no known cause nightmares and kids I've worked with. And that way it'll be like completely different things. Dinosaurs one day, sharks the next.
Both scary.
Yes, definitely. Yeah, and that's the big thing. They're always scary though. You're like, wow, that's scary.
Wow. Yeah. You're like, I would wake up scared from that too. That sounds intense.
Yeah, exactly.
And how many patients are you guys working with on a regular basis?
That's a good question. I think it's about like 4 to 6 people we have at some point in the study at any given point. So the way our study works procedure-wise, people are coming in, they do the consent, then we do a baseline assessment to make sure that they're eligible. And then after that, they're randomized to either start the treatment or to a wait list. And so at any given time, we might have like only a couple therapy participants, but we still have people involved because they're doing like baselines, they're doing the wait list, and then post-assessment after.
Okay. Yeah, when you were saying that you guys are calling households and stuff, I was like, oh my God, like you're working locally and it sounds like a lot of people have nightmares even just there.
Yeah, which we do also. We can treat anyone in the state of Oklahoma, and we do our treatment virtually. Most people are still located within Tulsa, but that helps get some other people. Like we've had people from Oklahoma City, Norman, all around.
Gotcha. Okay, so no one's traveling out of state. It's only local to Oklahoma.
Yeah, that's just the way psychology licensing works. We're licensed for a specific state. So, yeah.
Gotcha. Can you talk about your therapeutic approach? So you have patients who are coming to you with nightmare disorder. How are you treating that with them?
Yeah, so our therapy is called cognitive behavioral therapy for nightmares in children, or CBT&C. And so with that, we have kind of the cognitive piece and the behavioral piece. So on cognitive, we're really focusing on changing any thoughts related to nightmares. So one type of thought that can perpetuate nightmares is the thought that I'm going to have a nightmare. And so really trying to instill like control over the nightmares and that you can have good sleep if you believe you're going to have good sleep. And then on the behavioral side, we're focusing more on like what are the behaviors that the child or teen is doing that might be making the nightmares more likely to happen. And so a lot of instilling good sleep habits and adjusting behaviors so that sleep is more likely to be good as well.
How have your patients reported their nightmare disorder has affected their lives?
Yeah, so big things are like school performance or like just going to school. So students or kids are less likely to want to go to school because they're tired. And so it impacts their attendance. Or if they do show up, they might not be doing as well in school. Also in relationships. So people will say like on nights I have nightmares, like the next day I'm more irritable or angry or maybe more reactive. And so that leads to maybe more conflict with family, friends, teachers, just overall mood in general. So there's a lot of research to support too that people who have nightmares are more likely to have other symptoms such as depression, anxiety, and even suicidality.
Oh,
And
wow.
so that's one of the big reasons why we do the study is like the hopes are to reduce suicidality by reducing the nightmares. And we have seen like people that I've worked with have said like after this, because I have fewer nightmares, I'm not as suicidal because it feels so distressing and lonely to have these nightmares. And now that I'm having fewer or none, I don't have those feelings anymore. So many different ways, I guess, is the answer to the question.
Yeah. How long are you guys treating nightmares, or how long are patients working with you?
Yeah, so our therapy is 5 modules. And so usually it's 5 to 6 times that we're seeing them for therapy.
Okay. And it's once a month or
Once a week.
once
Yeah.
a week? Okay.
Mhm.
Wow. That's pretty amazing that they're seeing results that quickly.
Yeah.
I mean, I
And
guess I say quickly, but if I'm like waking up every night from a terrifying dream, maybe that's not very fast. It's like 6 weeks that's tough to be dealing with that. I was going to ask if you wouldn't mind walking through the 5 modules and what's happening at each stage.
Yeah. Okay. So let's see. So module 1, we start with mostly just introduction, trying to understand what their hope is out of the treatment and what life would look like after treatment. So really trying to instill hope that this can help. And then one kind of active behavior change that we're making during that is a bedtime routine, because we know that having a consistent bedtime routine is very helpful for like falling asleep and helping your mind know that it's time for bed. And something I can add with that I didn't mention earlier is that a lot of these kids are also meeting criteria for insomnia disorder. And it's which one came first in some ways unclear, but a lot of times, there's an avoidance of sleep or in trouble falling asleep because of the fear associated with bedtime. And so bedtime routine kind of more actively helps with the insomnia symptoms as well, like knowing this is my time to fall asleep. Module 1, we also do belly breathing, which is a relaxation exercise recommended also for insomnia disorder and just feeling relaxed before bed.
Is that just like deep breathing?
Yes, and really focusing on breathing from, your diaphragm or your belly, because that's really where your parasympathetic nervous system is able to be activated. So we'll sit there and be like, okay, put one hand on your chest, one hand on your belly, make sure that the belly is what's moving the most. Module 2, we do a worry jar. And so the idea of this is because a lot of kids and teens with nightmares and just people in general who are having nightmares have a lot of worries, or it can be one of the causes. And so a worry jar is the idea that we put all of our worries in this worry jar and we only look at it once a day for, 5-10 minutes max to think about the worries and then it's only that time. And so the big thing there is also reinforcing that we are not worrying in bedtime. We are only worrying at this one time during the day with the worry jar.
You're like scheduling it out.
Yeah.
Okay.
Like this is when I'm scheduled to worry. And so it helps with the cognitions too, because it's like, oh, I don't need to worry about that right now because I have it scheduled for 4 p.m. and I'll worry about it then. Which I love to use too, especially as a grad student doing so many things. I'm like, I don't need to worry about dissertation. I have time scheduled for it. So yes, we do that then. And then we also start going over some healthy and unhealthy sleep habits. And that's where it really becomes very individualized because depending on their habits, kind of depends on how serious the intervention needs to be and how much maybe shaping or changes we need to make in terms of sleep habits. And then mod 3, we do a pillowcase. And so the idea of the pillowcase is we give them a pillowcase and they draw on the pillowcase all the things that they want to dream about. And so this is meant to serve as a reminder that they can have good sleep and have these good dreams. So really that's where it's like some of that more cognitive work of like, I go to sleep, this is what I can dream about. And I'm excited for that rather than I don't want to sleep. I'm worried about having a nightmare. And then we do progressive muscle relaxation, but we call it with the kids tighten and relax each muscle or trim. And we have a little video that we do with them where they're just focusing on tightening and relaxing. And that's more to help them realize that they have control over their bodies in that way. And then module 4, that's when we do the exposure and rescription. So we ask them to recount their scariest nightmare in great detail. And then we change the nightmare to be something that they want to dream about based on whatever theme is found in the nightmare. So those themes that we identify are from cognitive processing therapy, which are related to traumas typically. So safety, power, control, intimacy, esteem. These are all categories of themes that are typically associated with trauma. So what we'll see with people who have like PTSD, for instance, a lot of their cognitions or struggles are associated with feeling like they can't trust people or feeling like they don't have control or power. And so these are all themes that are really rooted in trauma therapy that we also see are typically related to those nightmares. So there's often people are scared for their safety in a nightmare. And so we figure out which theme is most prevalent in their nightmare, and then we change it. So if they felt unsafe, how can we make this nightmare something that is safe? And then, that really helps with the cognitive piece of feeling in control, while also the exposure in general is a more behavioral principle of desensitization to the nightmare.
How are they reframing it? Are they like explaining how they would change it to you guys verbally, or are they writing about it, or are they actually trying to envision it in their minds?
Yeah, we give them the option to just talk about it, draw it, or write it, whatever they want. They definitely at least have to talk about it with us. And then their homework for that week is to read the change dream and really imagine it each night before bed to also help them know, like, oh, I can change my nightmares. And the goal too in that is that when they do have a nightmare, if they have a nightmare, in the next week, they can change it in the moment to help them go back to sleep faster.
Okay, fascinating. Thank you for walking me through that. How effective have you guys found your therapeutic approach? Are you finding that all of your patients are seeing improvement in their nightmare disorder?
That's a great question. So in terms of all, I wouldn't say all have been improved, but overall, we just published last year an efficacy study that showed that overall, like people who got the treatment in comparison to the wait list, there was a significant improvement if they got treatment. And then just comparing everyone who got the treatment from before and after, there was a significant improvement in nightmare frequency, nightmare distress, nights with nightmares, and overall mental health changes as well. And even if they don't report the decrease in the symptoms, most people are reporting some increase in quality of life. So even if it's that they're still having nightmares, they're maybe able to go back to sleep more quickly and they're not waking up their parents or things like that are still happening. So overall, most people are benefiting in some way from the treatment for sure.
In the work that you guys are doing, I was reading a little bit about it, and from what I understood, it sounds like oftentimes nightmare disorder is due to a past trauma or some kind of traumatic experience. Is that the case?
Yeah, so there's a lot of different reasons nightmares can occur, and definitely trauma is one of the big ones, especially with like adults, which I think is some of the difference too. So, yeah, nightmares are very common after a trauma, but they don't have to be. I think I mentioned a little bit also that stress in general can cause nightmares. So, some people with just like an anxiety disorder might be more likely to have nightmares even in the absence of a trauma. Also, there's a recent hypothesis by Nielsen in 2017, so I guess a few years, but they suggested that nightmares that appear to not have a cause, so not related to a trauma, may actually just be due to like early childhood adversity that affects the brain architecture. So it could be trauma related or kind of this more early adversity related, maybe more stress related. So there's a lot of different things that could make nightmares more likely to happen.
And by early adversity, do you mean like kids who are from a historically oppressed group, or like they experienced something personally separate from like their demographic identity?
I think it can be both, just any kind of experience that could be leading to more likely to like have stress or adjustment. The main difference between that and like trauma is for, especially when you think about it in this very rigid DSM-5 criteria, for when we talk about like a trauma related nightmare, it's really related to that PTSD, post-traumatic stress disorder description of what a trauma is, which is very specific in that it needs to be actual or threatened death, serious injury, sexual violence. So certain events that don't necessarily meet the criteria for that can still be an adverse experience that is very stressful and maybe make you more likely to have nightmares, but not be a criterion A PTSD trauma.
Yeah. On the topic of trauma, I know you said that you're finding that nightmares are more common in early childhood. I wondered if the definition of trauma is different for different age groups. Like, there are things that are objectively traumatic, like a loss of a loved one or something. I think everyone would agree that that's a traumatic experience. But for a kid who's so small, maybe getting stung by a bee or something really like upset them and disturbed them. And I was wondering if that is a consideration at all, like what constitutes trauma for a different age group.
Yeah, and definitely, I think it depends on too, like, based on, if you want to just go based on like DSM-5, we would say criteria for a trauma is the same. We take a more lax approach in some ways of just understanding, like, was this scary or stressful? Like, did this experience cause you to fear your life? Even if it was like a bee, we know objectively, unless you're allergic, that bees are likely not going to cause death. But if that was the cognitions that you had in relation to it, and so this was a very, very scary event, we're counting it, at least in terms of our conceptualization of how this could relate to their experiences.
That makes sense. And can you explain what DSM-5 is? Is that the like guidelines that you guys are using?
Yeah, so the DSM-5 is the Diagnostic and Statistical Manual. It's from the American Psychiatric Association, which tells us all of our diagnoses. So like generalized anxiety disorder, major depressive disorder, nightmare disorder, all of those are laid out there with specific criteria that people need to meet to be able to have a diagnosis. So like when insurances are asking what diagnosis, it's based on DSM-5, like did they say yes to all of these things? For our study, we require people to meet criteria for nightmare disorder based on DSM-5 criteria.
Is it essential to your therapeutic approach with kids, if their nightmares are stemming from a traumatic experience, that you identify what the experience is or was?
So that's a great question. For our specific therapy, we allow it to be trauma related or not trauma related. And so we do before in that baseline assessment, ask like for traumas, and we assess to understand for just understanding the case more so, but we don't technically, like, it doesn't matter as much like what the trauma is for our therapy to work. So we do ask about it. And usually if there was a trauma that was 100% related to it, they're talking about it in that way, but it's not like structured piece of our therapy.
Okay, that makes sense. I was just thinking that kids have such weird minds and thoughts, and that it might not always be possible for them to even pinpoint what's causing a chronic fear of something.
Yeah, which is also why we kind of don't require it to be, because it might be that it is related to a trauma. They just can't really process that. And so we would be losing people who just don't maybe have the insight, and then they just don't get help because they don't have that insight. So that's why we're just like, we'll help you regardless. And so far, I mean, it seems to be working regardless.
Okay.
Right? Yeah.
Yeah, that makes sense. Yeah, this is so random, but when I was a kid, I had this irrational fear that, you know, the space under the seat in front of you in the car, like where you put your feet. When I was sitting in the back as a passenger, I would always like lift my legs onto my seat like this because I thought that there was people living under the seat that had hamburger patties for heads that were like gonna eat me or something. And it is such a vivid idea, and I could not tell you where that came from. I have no idea, like, if I watched something or I had an unsettling experience. I don't know. I just feel like kids, sometimes their fears are really specific and yet difficult to identify even for them.
Yeah, no, that's so funny.
Yeah. This might be too broad a question. If you don't have an answer for it, that's fine. It's just something that I just thought of. Is there any sense that nightmare disorder is more common in some locations than others? Maybe because of environmental factors or the culture of an area?
That's a good question. I don't know if there's any research specifically. I feel like there could be reasons why, in terms of like stress, especially because we know nightmares are more common for people with a lot of anxiety. So if you think about maybe locations where people are maybe less accepted for who they are, maybe experiencing more stress in that way, maybe more likely to have nightmares. But that's just the hypothesis theory.
Yeah, that's interesting. I guess it's tough to know because you guys are just working in Oklahoma at this time. Okay, to back up a little bit, what constitutes a nightmare and how is it different from a bad dream?
Yeah. The main way that a lot of researchers, including my team, will differentiate is the waking criteria. So a nightmare is a bad dream that wakes you up. And the reason that that's specified is because of theories regarding why nightmares are like maintained. So there's a belief that waking up from the nightmare, you're not able to do the emotional processing that would occur if you were able to sleep through it. That's occurring during sleep. And so a lot of people use that waking criteria. However, the DSM technically doesn't say like you have to wake up from a nightmare. It just says upon awakening, the person's alert. So there's some discourse in the research field as well right now as whether that waking criterion is necessary or not.
That's interesting. So if you are like waking up in a cold sweat, that's a nightmare. But if you wake up normally and you're able to recall that you had like a disturbing dream, that's a bad dream?
Yeah.
Okay. Gotcha. As far as current research tells us, why do we get nightmares at all?
Yeah, I feel like a lot of this is super theoretical. I mean, some of it's more known. So like we know that traumas are likely to happen. So during sleep is really when we're emotionally processing like our memories in the day. And so if during the day your emotions are filled with stress, if there's traumatic events that are also likely associated to stress, during that emotional processing stage of sleep, it seems that it kind of gets stuck there and you're not able to process, and that's why you're waking up. And because of that, not getting fully processed, you're more likely to continue having it. And the habits that end up getting associated with trying not to have nightmares or trying not to like be upset by it or avoiding nightmares in general are maintaining the nightmares once they happen. But there's other things that kind of cause nightmares too. Like I mentioned caffeine for myself. There's some kids that I've worked with where they just like stop drinking caffeine at dinner, nightmare's gone. And we're like, great,
Wow.
okay, done. So like certain substances can influence it. Yeah, I guess those are the main things. Oh, and then I talked about, I think at one point, the early adversity as a way of impacting your brain architecture. And so because of that changes, you're just more likely to have nightmares during that time because of all the things your brain is doing during sleep. So.
Mm. Yeah, I'm familiar with the concept of sleep hygiene. I'm not good at it. Definitely don't practice it like I should. But for anyone who isn't, can you explain how anyone at any age could get better sleep?
Yeah. Oh my gosh, love. So there's so many different things that you can do. And I want to acknowledge before I go into things too, that it's all really dependent on who you are as a person. So there's some things that, Bobby over here might be able to do, but Hannah over here, if she were to do that, she wouldn't get sleep. So these are all things that can help. Big things though. Bed is for sleep only, no schoolwork, no eating, anything else. Then also trying to go to sleep and wake up at the same time every night and morning consistently. Having a clear bedtime routine before bed to help your brain know it's time to go to sleep. And so a bedtime routine can just be like 30 minutes before bed doing the same thing in order. And it can be small things. So like I brush my teeth and then I change into pajamas and then I turn off the fan or turn on the fan and then I turn off the light and then I go into bed. I put on my sleep mask. Routine. Done. If you do that every time each night, your brain's more likely to know it's time for bed. No caffeine. Usually they recommend 8 hours before bed. No caffeine. But again, that's also really dependent on your body. Sweets and sugar in general too close to bed also can be impactful. Oh, also, especially nowadays, screen use before bed. You usually want to stop it within like 30 minutes before bed, if not longer, like an hour.
Gotcha.
And wearing a sleep mask. Ooh, yeah. Sleep mask, like having a dark, well temperatured environment. Also, if your pets are going to bother you, like no pets in bed, that's also recommended. Doors shut, no sounds, those kinds of things.
Yeah, that's all good advice.
Yeah.
That everyone should follow, and I'm sure almost no one does. Thank you so much for being here, Lauren.
Yeah, of course. Thank you so much for having me. I enjoyed talking about this, and yeah, I hope it was helpful.
It definitely was. And thank you, everyone, for listening to this Halloween special of Itsy Bitsy. Until next time.